Acquired von Willebrand syndrome. Introduction. Acquired von Willebrand syndrome is a rare but probably underestimated bleeding disorder characterized by laboratory findings and clinical presentations similar to those of inherited von Willebrand disease. Differing from von Willebrand disease, a bleeding disorder due to quantitative or qualitative genetic defects of von Willebrand factor, VWF, acquired von Willebrand syndrome usually occurs more frequently in adults with no personal or family history for a bleeding diathesis. Although it was first recognized more than 50 years ago, it was described in 1968 in a patient with systemic lupus erythematosus. Acquired von Willebrand syndrome has gained renewed interest in the last few years due to its association with relatively frequent cardiovascular disorders, including congenital heart defects, aortic stenosis, and the use of left ventricular assist devices. In addition to these, many other underlying diseases are associated with acquired von Willebrand syndrome, ranging from solid and hematologic cancers to autoimmune diseases. Various mechanisms are implied in the pathophysiology of acquired von Willebrand syndrome, the majority of them leading to the increased degradation or clearance of circulating von Willebrand factor. Pathophysiology, clinical presentation, diagnosis. Pathophysiology. Unlike acquired hemophilia, another rare acquired bleeding disorder caused by autoantibodies that neutralize FVII coagulant activity, the complex pathophysiology of acquired von Willebrand syndrome involves various and different mechanisms. Most cases are due to an increased plasma clearance of von Willebrand factor caused by such mechanisms as antibodies, cell adsorption, shear stress, or increased proteolysis. At variance with acquired hemophilia, acquired von Willebrand syndrome almost always occurs in association with an underlying disorder. Besides cardiovascular disorders, those more frequently associated are lymphoproliferative disorders, multiple myeloma, chronic lymphocytic leukemia, monoclonal gammopathy of undetermined significance, MGUS, Waldenstrom macroglobulinemia, and, less frequently, other hematologic malignancies, myeloproliferative neoplasms including essential thrombocythemia, polycythemia vera, primary myelofibrosis, and chronic myeloid leukemia, solid malignancies, and autoimmune disorders. The different underlying disorders lead to acquired von Willebrand syndrome through different mechanisms. In patients with hyperthyroidism, the syndrome is caused by the decreased synthesis of an otherwise qualitatively normal von Willebrand factor, and this can be reversed by L-thyroxine therapy. In cardiac valvulopathies and left ventricular assist devices, shearing of high molecular weight, HMW, von Willebrand factor multimers by mechanical stress or proteolysis induced by ADAMTS13, a disintegrin and metalloproteinase with a thrombospondin type 1 motif, member 13, are involved. In cases associated with plasma cell dyscrasias, MGUS and multiple myeloma, as well as in autoimmune diseases such as systemic lupus erythematosus, circulating autoantibodies directed against functional or non-functional von Willebrand factor domains have been reported. Antibody binding to von Willebrand factor leads to the formation of immune complexes that are cleared from the circulation by the reticuloendothelial system. Antibodies that neutralize platelet-related von Willebrand factor activities, inhibitors, have seldom been reported. Finally, a mechanism involving the selective adsorption of HMW multimers on tumor cells leading to their enhanced plasma clearance has been described in lymphoproliferative diseases, multiple myeloma, Waldenstrom's macroglobulinemia, non-Hodgkin lymphoma, hairy cell leukemia, and solid cancers. In MGUS, the aberrant expression on abnormal plasma cells of the glycoprotein IB was associated with its selective binding to these cells. Von Willebrand factor adsorption onto the cell membranes and subsequent plasma clearance has also been involved in acquired von Willebrand syndrome associated with myeloproliferative neoplasms. For example, adsorption on platelets is the mechanism in essential thrombocythemia, with an inverse relationship between platelet count and the plasma defect of HMW multimers. In addition, essential thrombocythemia and other myeloproliferative neoplasms may cause the syndrome through increased plasma von Willebrand factor proteolysis. Clinical features. The bleeding diathesis usually occurs rather late in life in persons with no past and family history of bleeding. The main symptoms are mild to moderately severe mucocutaneous bleeding, ecchymosis, epistaxis, menorrhagia, gastrointestinal tract bleeding, similar to inherited von Willebrand disease, or excessive bleeding following trauma or surgical procedures, particularly when FVIIIC is low. Gastrointestinal bleeding is usually associated with the detection of angiodysplasia. A few studies have investigated the association of myeloproliferative neoplasms with acquired von Willebrand syndrome. Diagnosis. In the absence of a family history of bleeding, the diagnosis of acquired von Willebrand syndrome is usually based on the laboratory tests used to diagnose inherited von Willebrand disease. Plasma samples usually show normal or mildly decreased VWF, Ag, contrasting with a more marked decrease in VWF ARCO and VWF CB. The latter qualitative platelet-related activity assays of von Willebrand factor are frequently lower than the quantitative VWF, Ag assay, resulting in VWF ARCO VWF, Ag ratios that are often below 0.7, similar to type 2A VWD. When FVIIIC is low, a prolonged APTT is also observed. Von Willebrand factor multimer electrophoresis is warranted to demonstrate the defect of HMW multimers that helps to distinguish acquired von Willebrand syndrome from type 1 VWD. Measurement of the plasma von Willebrand factor propeptide, which reflects the degree of von Willebrand factor biosynthesis, is not currently recommended to distinguish inherited VWD from acquired von Willebrand syndrome because the latter is often characterized by an accelerated clearance of von Willebrand factor from the circulation but normal synthesis, so that propeptide levels are normal. At variance with acquired hemophilia, autoantibodies that inhibit platelet-related von Willebrand factor activity play a mechanistic role in a minority of acquired von Willebrand syndrome cases. Nevertheless, because the presence of neutralizing antibodies seems to be associated with a more severe bleeding tendency, antibody screening should be performed in all acquired von Willebrand syndrome cases. The most common method used to look for an inhibitory activity against von Willebrand factor is based upon mixing studies, patient plasma mixed with normal plasma and incubated at 37 degrees Celsius, followed by the measurement of both residual VWF, ARCO and VWF-CB. However, an inhibitor is seldom demonstrated and the antibodies that bind von Willebrand factor and accelerate its plasma clearance without neutralizing von Willebrand factor activity cannot be detected with this method. Enzyme-linked immunosorbent assays, ELISA, are an option that has, however, not yet been adequately standardized. Overall, diagnosis of acquired von Willebrand syndrome is difficult, and a correct workup should consider all information from both clinical and case history evaluation as well as laboratory results. In particular, the differential diagnosis with milder forms of inherited von Willebrand disease is important given the difference in therapeutic approach. Treatment. There are three main treatment goals for patients with acquired von Willebrand syndrome: the control of acute bleeding, its prevention in high-risk situations, and the achievement of a stable remission or cure of the syndrome. Removal of the underlying disorder, i.e. by means of surgery, chemotherapy, radiotherapy and/or immunosuppressants, is the only potentially curative approach. However, treatment of the associated condition may not be feasible, and a partial remission does not always ameliorate the bleeding symptoms. As far as the hemostatic therapies are concerned, a range of different medications have been used. Desmopressin, DDAV. VWF FVIII concentrates. Antifibrinolytic agents. High-dose intravenous immunoglobulins, HDIVIG. Plasmapheresis. Recombinant activated factor 7. DDAV. The ISTH registry reported an overall success rate with DDAV of approximately 30%, although this varied according to the underlying disorder, lower in cardiovascular disorders, 10%, and myeloproliferative neoplasms, 21%, and higher in autoimmune, 33%, and lymphoproliferative, 44%, disorders. In a prospective trial performed in 10 patients with MGUS, plasma VWF levels increased in all patients after DDAV, but the increase was short-lasting. A short plasma half-life of von Willebrand factor following DDAV administration has also been observed in the context of other lymphoproliferative disorders and is thought to be related to the presence of anti-von Willebrand factor antibodies. A transient effect of DDAV was also observed in patients with myeloproliferative neoplasms, mainly due to adsorption or proteolytic cleavage of the released von Willebrand factor. It is advisable to closely monitor FVIIIC and VWF-ARCO-VWF-CB plasma levels after DDAV in order to maintain these at levels that are sufficient to prevent or treat bleeds. Concentrates. In the ISTH registry, VWF-FVIII concentrates showed a favorable response in approximately 40% of cases, with dosages ranging between 30 to 100 VWF-ARCO units kilogram. The half-life of infused VWF is shorter than in inherited VWD, thus requiring higher doses of VWF-FVIII concentrate to ensure adequate hemostatic plasma levels. Plasma FVIIIC and VWF-ARCO must be monitored when administering DDAV, particularly in patients undergoing invasive or surgical procedures. Antifibrinolytic agents. The antifibrinolytic agents most commonly used in acquired von Willebrand syndrome is tranexamic acid, at a dose of 20 to 25 mg/kg every 8 to 12 hours. These drugs can be given orally, intravenously, or topically, and act by inhibiting plasminogen activation. Antifibrinolytics are primarily used as adjuvants together with DDAV or VWF-FVIII concentrates for surgery and bleeding, particularly at sites with high fibrinolytic activity. However, these drugs may be used alone for minor bleeding episodes. IVIG. HDIVIG is especially useful in cases associated with MGUS. HDIVIG is more effective than DDAV and VWF-FVIII concentrates in MGUS because there was a more sustained increase in FVIII-VWF activities and shortening of bleeding time for at least 15 to 20 days in all IgG-MGUS cases. In contrast, no response was observed in patients with IgM class MGUS, IgM-MGUS. In addition, prophylactic infusions of HDIVIG every 21 days stopped recurrent gastrointestinal bleeding in patients with IgG-MGUS. The mechanisms of action of HDIVIG may involve an anti-idiotype effect, blockage of reticuloendothelial Fc receptors, or capture of the circulating immune complexes by the immunoglobulins. The recommended doses of HDIVIG are 1 g/kg for 2 days or 0.4 g/kg for 5 days. The increase in von Willebrand factor and FVIIIC levels usually occur within 24 to 48 hours and may last up to 3 to 4 weeks. Thus, additional courses of HDIVIG every 21 days are necessary to maintain a clinical response. Due to the delay in the post-infusion increase in von Willebrand factor and FVIIIC levels, HDIVIG is not effective in the management of acute bleeding. In these cases, the medication must be administered together with shorter-acting agents such as DDAV and VWF-FVIII concentrates. Plasmapheresis. The main goal of plasmapheresis is to temporarily eliminate autoantibodies and paraproteins from the circulation. This procedure is particularly effective in IgM-MGUS, which generally responds poorly to other treatments. Recombinant factor 7. Finally, recombinant factor 7, usually administered at a dose of 90 g/kg for a median of 3 doses, has been successfully used when bleeding associated with acquired von Willebrand syndrome is unresponsive to DDAV and VWF-FVIII concentrates. Specific approaches according to underlying disorders. Lymphoproliferative and autoimmune disorders. Desmopressin or von Willebrand factor containing concentrates typically result in short-lived improvements of von Willebrand factor. Patients with IgG autoantibodies and paraproteins usually respond well to IVIG. Improvement of von Willebrand factor measurements is typically observed after 12 to 72 hours and lasts for several days or weeks. IVIG has been recommended for second-line treatment in patients unresponsive to desmopressin or VWF-containing concentrates, but in our experience can be the better choice for severe and recurrent bleeds because of the longer-lasting effect. Because IVIG is not immediately effective, simultaneous use of VWF-containing concentrates can be necessary in the first few days. Patients with paraproteins of the IgM class do not respond to IVIG. Plasmapheresis combined with von Willebrand factor-containing concentrates has been reported to be effective. In addition, antifibrinolytics can be helpful, particularly for mucocutaneous bleeds. How to induce long-term remission? Treatment of the underlying disorder should be considered whenever possible. If MGUS becomes symptomatic because of acquired von Willebrand syndrome, an effective long-term therapy would be highly warranted but unfortunately has not been established. Chemotherapy and steroids are usually ineffective, apparently because these drugs cannot eradicate slowly proliferating plasma cell clones. Rituximab has also been used without success in one reported case. Another case report suggests that the proteasome inhibitor bortezomib could be effective. At this time, however, IVIG, 4-IgG-MGUS, and plasmapheresis, 4-IgM-MGUS, remain the only treatment options for most patients. For patients with B-cell lymphomas or multiple myeloma, successful chemotherapy, combined with rituximab if appropriate, can result in remission of acquired von Willebrand syndrome with an overall success rate of 35% to 70%. Steroids, other immunosuppressive drugs, and IVIG, 4-IgG von Willebrand factor-binding antibodies, should be considered in autoimmune disorders. Myeloproliferative neoplasia. Acquired von Willebrand syndrome associated with myeloproliferative neoplasia, MPN, primarily results from adsorption of von Willebrand factor to transformed blood cells, in particular platelets. It has been reported in essential thrombocythemia and polycythemia vera, but also in chronic myeloid leukemia, primary myelofibrosis, and sometimes in acute leukemia. Although risk factors for bleeding in MPN have not been well described, most reviews concluded that a very high platelet count, 1500 NL, is a significant risk factor. Additional risk factors, such as platelet function defects, contribute to bleeding. For the time being, we suggest that bleeding patients with MPN be screened for both acquired von Willebrand syndrome and platelet function defects. How to treat bleeding patients with MPN? Cytoreductive therapy was reported to result in remission of acquired von Willebrand syndrome patients with MPN and should be considered in bleeding patients. Higher doses von Willebrand factor-containing concentrates sometimes result in better treatment results. Alternatively, recombinant factor VII may be considered for severe bleeding refractory to other treatment modalities. Thank you for listening. Please share this video with your colleagues and friends.